for me to observe and recognize every day. Madam Chair, it is a privilege for my colleagues and I to appear before this committee today to share with you.
Thank you very much. And now we will begin the question and answer period, and I'd like to say that it's a 6-minute round, and 6 minutes includes a question and answer. So just be reminded of that, and I will give you a time call when I think you're getting near to the end of that time period. So we will begin with a 6-minute round, starting with Mr. Mazier for 6 minutes for the Conservatives. Mr. Mazier.
Thank you, Chair, and thank you to the officials for coming out this morning. My questions will be for Health Canada. Ms. Weber, Health Canada is the federal department that approves supervised consumption sites. Is this correct?
Yes. When a request comes in to seek an exemption to put in place a supervised consumption site, Health Canada reviews the exemption request for public health and public safety.
According to Health Canada's website, a supervised consumption site is a place where, and I quote, a person brings their drugs to a site to consume. Depending on the site, drugs are injected, snorted, inhaled, or consumed as pills, end quote. Is that description still accurate?
The supervised consumption sites provide a place for individuals to go to use the illegal substances in a place where there is supervision, so that if there is an overdose, there is support for the individual.
So it is a place where they consume, where drugs are injected and snorted and inhaled?
Yes.
That's what they do. Okay. Is crack cocaine allowed to be used in some federally approved supervised consumption sites? Yes or no?
The supervised consumption sites are approved, taking into consideration public health and public safety concerns. And so they provide a place for individuals who use substances to go into a supervised place to use illegal drugs.
So crack cocaine could be allowed to be used in these federally supervised sites?
Illegal drugs are used in the supervised consumption sites so that individuals...
As
an
an
assortment
example?
of illegal drugs. Yes, illegal drugs are used in supervised consumption sites, so individuals have health practitioners who are nearby to oversee if there's an overdose and to prevent death.
So is meth allowed to be used in these sites?
Illegal substances are used in supervised consumption sites so that health practitioners can be there to oversee if there is an overdose.
So meth is allowed to be used in these sites? It's an illegal substance.
Illegal substances are allowed to be used in the sites. They seek an exemption from the Controlled Drugs and Substances Act so that health practitioners can be there to oversee the use of the drugs in case there's an overdose.
What is the most common drug used at the supervised consumption sites that Health Canada approves?
I don't have the most common drug, but I suspect it's fentanyl, given that the largest volume of deaths that we see right now are associated with the use of illegal fentanyl across Canada.
Yes, and you're right. According to your website here, it is fentanyl. 49% of visits to the supervised consumption sites that your department approves includes fentanyl for use. Is that correct?
So what's important is that the supervised consumption sites seek the organizations come in to seek an exemption from the Controlled Drugs and Substances Act so that individuals can go in and use illegal substances, and a health practitioner oversees the use in case there's an overdose.
And yet 49% of those visits are due to fentanyl. According to your website, that's all I'm confirming.
So
your website is correct.
So the most toxic
is what I guess my question is.
Yes, and there are individuals across Canada who are using illegal fentanyl, and the sites provide a place where they can go in to use them, and there's a health practitioner to oversee and support in case of overdose to prevent death.
Thank you. Health Canada is considering an application.
2 minutes.
Thank you, Chair. Health Canada is considering an application for a supervised consumption site in Whitehorse, Yukon. The location is only 200 meters from the Whitehorse Elementary School, 300 meters from Learnville Daycare, and 400 meters from Footprints Daycare. Will you commit today to rejecting this application given its proximity to children's schools and daycares?
So we will, if that request is in for review, we will assess it based on public health and public safety. And one of the key components that is involved in an exemption request from the community is consultation with the community. And so that will be a key component of the application coming in from the community to look at community consultation, to look at the public health needs, and also the public safety needs.
So you're not willing to commit today to rejecting this application, being that it's this close? You have illegal drugs 200 meters away from public schools, public daycares, and you're not willing to commit to that today. You can't give any indication to the public how you're considering this. So you will either reject or seriously consider rejecting this proposal.
We review each exemption request on a case-by-case basis.
So you can't give me a yes or no. Okay, that's good. I have another question for you anyways. Does Health Canada automatically reject
30
applications?
seconds.
Does Health Canada automatically reject applications for supervised consumption sites if they're next to schools or daycares? Yes or no?
We do not have a prohibition in the legislation related to the distance from schools. Some provinces in Canada do have restrictions around the distance from schools. In particular,
Has Health Canada ever received reports of discarded drugs, used needles, or crack pipes ending up in school playgrounds or daycare yards next to the supervised consumption sites that the department has approved?
I can't speak to the complaints. I can't think. We are aware that there is public use of substances in communities.
But you've never had reports come across your desk? Thank you, Chair.
And now I'll go to Ms.
Thank you all for coming. It's a pleasure to see everyone here today. My question, some follow-up for Ms. Weber regarding supervised consumption sites. To your knowledge, how many overdose deaths have taken place at supervised consumption sites in Canada?
No deaths, but the sites have responded to over 65,000 overdoses, and they've been visited more than 5.3 million times.
Okay. Can it be a reasonable assumption that had these people been consuming them in other places other than a supervised consumption site, they would have had a significantly higher chance of dying?
If there were not the supports needed, such as naloxone, to save the individual, then that could be the case.
Okay, thank you. Thank you. Now, there have been reports, people saying that there are, things like crack pipes, discarded needles found near these places. When someone has at a safe consumption site, when someone is using a needle, do the people take these needles with them, or are they disposed of on site?
There is safe disposal on site.
All right, thank you. Is there any estimate on disease prevention? We do know that reusing needles can increase the risk of transmission of diseases like HIV, hepatitis B, hepatitis C. Is there any data or evidence on what the supplying of clean needles to these people using at these sites, the burden of disease that would have been prevented at these sites?
Yes, definitely. The burden of disease is reduced. The actual origin of supervised consumption site a few decades ago actually originated around the time of HIV and also infectious disease.
Mm-hmm. All right, thank you. Ms. Hamzawi, regarding mitigation of outbreaks, there's various estimates on in the medical literature on this. The public health actions taken during the pandemic were controversial and not generally not accepted by a lot of people. Is there an estimate of the number of lives that were saved in Canada by these public health measures that were taken in Canada?
I don't have, thank you for the question, Madam Chair. I do not have the specific number handy with me now, but I can get back to you with the number of lives saved. But I don't have that number. I'll get that back to you.
Okay, thank you. During the pandemic, am I correct in what I've understood, that the relative mortality due to COVID in Canada was 1/3 that of the United States?
It was significantly less, absolutely, and that was thanks to an unprecedented, the largest vaccination campaign in the history of Canada. 152 million vaccines were distributed across Canada through.
All right, thank you. We were talking about the measles, the measles outbreak, and how it's increasing. You know, I'm seeing yet another headline from Manitoba yesterday of another large outbreak that's happening. That's my home province. Do we have any strategies on how we can better improve vaccine uptake in Canada?
Well, just on the measles in particular, just to note that this is an area of active collaboration with provinces and territories. This is all hands on deck, and in fact, the deputy and I were meeting with our deputy counterparts last week in Edmonton, and we did have a discussion around measles and how all governments are seized with this, and we are working together to make sure that we're bringing the best available information to Canadians. The vaccinations are being delivered for particularly, for example, populations who are particularly vulnerable, to be able to make sure that they have the information that they need so that they can make the proper decisions for themselves.
Thank you. I've been hearing claims that some of the measles outbreak and other newer infectious disease outbreaks are due to increased immigration in Canada. Is there any data to support that?
I'm not aware of any data to support that. As I noted earlier, 93% of cases are individuals who have been unvaccinated.
Okay. All right. Thank you. How much time do I have, Madam Chair?
You've got 26 seconds.
Yeah. I don't think I can ask a meaningful question then, so in that time. So thank you very much.
Now go to the Bloc Québécois. Monsieur Thériault, 6 minutes, please.
Merci beaucoup.
Thank you very much, Madam Chair. Welcome, everyone. My first question would be for Ms. Hamzaoui. Ms. Hamzaoui, congratulations on your new position. In September, you said you had cut 320 positions, and you actually said at the time that you had to redefine priorities, streamline some programs, and in some cases, cease activities in some areas. Are there some priorities you're going to do away with? Which ones? And what activities are you going to stop doing? Thank you very much for the question. I want to point out that we took these decisions very seriously as to any adjustments to our programming at the agency. Our mandate, and in fact the agency was born of a crisis and a pandemic, and our priority really is on health safety. Our cutbacks are rather a capacity reduction efforts, but we maintain the spectrum of activities at the agency. For instance, our health promotion and prevention of chronic diseases branch will continue. All the regulatory activities will continue. But based on the wealth of lessons we learned through the pandemic, we will strengthen our capacity in certain areas, key areas like wastewater usage, genomics and other capacity that we did not have prior to the pandemic, but there will be a drop in some areas. We will shrink some areas, but we haven't determined any specific area for cutbacks. Okay, so you can't tell me today what you will be cutting back on, what activities and what priorities. No priorities. Yes, thank you. Thank you for, I'd like to start by saying thanks for speaking to me in French. If you'd rather, you can certainly speak English. If you can do that, I have interpretation. It's faster and it gives me more time. I'll try to speak French faster. So the focus is on health safety. We will not be losing sight of any priorities. We will be adjusting our capacity overall. From what I understood, the cutbacks as a whole apply to all programs and could affect the national microbiology lab. Based on what I know, it is essential work when it comes to research, diagnostics, containment, biosecurity at the national and international level. Why cut back in this area? Can you ensure us that we will not be playing out the same pre-pandemic story that not this previous government, but the prior government had cut to such an extent that we were struck full frontal with this pandemic? How to make sure that the public, that people will be protected? Thank you very much, Madam Chair, for the question. These cutbacks are not the same in each branch. For instance, for the National Microbiology Lab, that is the branch that will be least affected compared to all other branches. The cutbacks had to do with this was more seeking out efficiencies or a focus on research studies that were perhaps more academic rather than applied. So this is the least affected of the entire agency. In branches such as the group that supports me and supports the public health officer, the cutbacks are 50% in this area rather than the lab, 10%. Whenever there's administration, that's where we've had the largest cutbacks. We certainly do not want to cut back from areas that have a major effect on Canadian public health. You referred to measles earlier and infectious diseases. We know that there is an issue with respect to vaccines. Can you assure us that you have everything you need in order to counter this trend and the fact that there are these illnesses that seem to be surging again? Absolutely. I am confident in the resources we have, that we are ready.
Thank you. Thank you very much, Mr. Theriault. I now go to the second round, and I'd like to clarify. I understand that in the second round, Mr. Theriault gets 6 minutes, and after that, he reverts to 2.5 in subsequent rounds. That is my understanding. That's okay? Everybody's nodding? Good, great, thanks. So, Ms. Conan, for 5 minutes, please, for the Conservatives.
Thank you so much. The experts in the room. Excited to find out more about your priorities. My first question, I think I will direct to Ms. Weber. In 2023, the BC government and federal government created a pilot program that allowed any adult to possess illicit hard drugs in British Columbia. Since then, more than 6,000 people, husbands, wives, daughters, sons, have died from drug deaths, and it's created havoc in our communities. This decriminalization pilot program is expiring in January 2026 to date. To date, have you received a request for an extension from the BC government on this deadly experiment?
No, we have not.
This is I think I'll ask the same question to you again, Ms. Weber, if I can, through the chair. This was a federally approved pilot program, a pilot project. I'd like to know, and I'm sure the residents of BC would like to know, what are the top 3 metrics you're using or you use to judge the success of this project?
So thank you for the question. So the DCRIM, the goal of the exemption related to personal possession of certain drugs was to reduce stigma and also reduce the fear of criminal prosecution that prevents people from seeking help. And it's the first exemption of its kind. And I think what's important is that throughout the exemption and through the oversight of the pilot project, that consultation continued with stakeholders. And BC actually came in twice to seek a modification and amendment to the exemption. As such, right now the exemption is limited to personal possession in homes or in addiction clinics, or also an overdose prevention site. So it's quite limited,
Ms. Weber,
and it's
excuse me,
illegal in public places.
I was wondering that's really good information. But what are the metrics you're using to judge the success of this project? We've seen thousands of people die on the streets of British Columbia, and it's been recommended by many experts that this project not continue. But you must have some metrics you're using. Otherwise, it wouldn't have continued to this point.
Thank you for the question. So we do require reporting from the province of British Columbia on a quarterly basis. They do put the reports on their website, and you'll see there that there are 4 dimensions to the reporting and the oversight and the metrics. The first being the utilization of healthcare services, the well-being of the people who use drugs, law enforcement, and of course public awareness and understanding of DCRIM. And so they report on different indicators under those 4 themes on a quarterly basis. It is actually published on their website for public review.
So you believe this has been a success, or you wouldn't have continued it up to this point? We have, unfortunately, drug-addicted people wandering the streets like zombies, high on drugs, is that deemed to be an acceptable outcome as part of this pilot program?
So we continue to monitor the exemption. It expires January 2026. We have not received a request for a renewal of the exemption.
If
it
you
has been
do
amended
receive
twice.
a request, excuse me, if you do receive a request by the British Columbia government to extend it, will you extend the program?
So we're not at the end of the pilot right now. When the request comes in, it will be under the Controlled Drugs and Substances Act.
1 minute.
And we'll assess public health and public safety and look at the indicators.
So right now, we have had requests from multiple communities to end this program. We've also had requests from RCMP. We've had requests from the British Columbia Association of Chief of Police and the Canadian Association of Police Chiefs calling on the federal government to reverse its position. Why hasn't your organization reversed this decision when you have the opportunity to give that advice to the minister?
So the province of British Columbia did come in to seek amendments to the exemption. And twice we've made amendments. And we have actually, it's narrowed down now to, as I mentioned earlier, the 4 locations where individuals can
Do you believe,
possess.
Excuse me, we're almost up. Time is up. 3 seconds left.
Do you believe this is a success, this program?
The exemption is not complete. So the exemption, it's a 3-year exemption until January of 2026.
I now go to the second round, a second person from the Liberals, Ms. Sidhu. You have 5 minutes.
Thank you, Madam Chair. Thank you, all the officials, to appearing at this committee today to share your important insight with Canadians. I would like to direct my first questions to Health Canada about artificial intelligence. Early this year, federal government announced the Pan-Canadian AI for Health Guiding Principles Could you please share with this committee on how these guidelines principle can play a transformative role in modernizing Canada's health system?
Thank you for the question, Madam Chair. So I'll take a crack at that. The principles were developed through collaboration with the provinces and territories and the federal government, and they are anchored in ensuring privacy, transparency, and accountability. And they're also aligned with some of the international best practices in this regard. They do provide certain rules for the road in respect of the safe and trustworthy adoption of AI in Canada's health system. By virtue of having these principles, they are promoting public trust and the responsible use of AI in health, and are also helping to ensure alignment across the country given the broad participation by provinces and territories.
The role AI can play in the future of health system. Does AI adoption in the health system help increasing the diagnostic efficiency within the primary care and emergency care, do you think?
So in terms of adoption, I think there are many promising ways in which AI can help transform healthcare in a number of different ways. From both detection to better diagnostics as well, while maintaining high standards and an appropriate use of resources. We're seeing a fair bit of adoption and success in terms of adoption in doctors' offices as it relates to AI scribes. For example, it's helping to relieve some of the administrative burden that practitioners are facing. It's being used in hospitals in terms of being able to sort of predict certain events, also being used to predict wait times, and it's also helping to support research and innovation predicated on having good, high-quality, standardized data to be able to use these kinds of technologies in the healthcare space.
Thank you. Just want to know about, you talked about we heard about the longer wait time. And do you think it can reduce the wait times and optimize allocation of medical resources? Do you believe in that, right?
So there have been examples of that in terms of that kind of deployment in large and complex settings in hospitals, for example. So it's been able to be deployed in that way, yes.
So my next question is to Health Canada and PHAC. Anybody can answer that. Could you please share with this committee with the present process of clinical trials in Canada, given that some Canadians are getting alternative treatment in the U.S. or other countries for a faster process? What is Health Canada doing to streamline the process while safeguarding our health standards?
1 minute.
So clinical trials obviously play a really important role in terms of advancing health research and effectiveness of medical treatments. And it's a very sort of active ecosystem. What we're doing at Health Canada is we are introducing new regulations to streamline the processes and the efficiency of establishing clinical trials, so that we can have more clinical trials take place in Canada to support innovation and access to drugs for Canadian patients.
Thank you. You have 18 seconds, Ms.
Just.
18 seconds.
Okay, I'll pass then.
Thank you. Mr. Thériault, Québécois, 6 minutes, please.
Merci, Madame la Présidente.
Thank you, Madam Chair. I'm going to turn towards Ms. Weber. Can we talk about recommendations 48 and 42 that came out of the Advisory Committee on Cannabis? Now, since the law came into effect, some issues have come to our attention for 4% more people are using cannabis, and there are some abuse cases. And when we look at production, it has also gone up. So on the website, we're being told that while this can take place, that this is normal, but when will you fully implement the recommendation from the advisory committee so that there's only one person per location?
Merci pour la question.
Thank you for the question.
I don't have the numbers of the actual recommendations that you're referring to from the report.
J'ai pas de traduction. Allez-y.
Go ahead.
Have the recommendations, the actual, the numbers that you've recommended or that you've mentioned. But if you're talking about personal and production of cannabis, and is that the number of licenses that we have in authorizations per home? Is that the question?
À des fins médicales.
For medical use.
Okay,
Oui.
merci.
On permettait donc.
So 4 people were allowed to produce at the same location, and the committee is saying that this needs to be reduced to 1 person. So when will you implement this? Because this is something that many people are waiting for. Okay, thank you. I understood you now.
Allow up to 4 individuals to have authorizations in their homes for medical cannabis. What we have done is taken significant measures to revoke or refuse those authorizations if we do see that individuals are growing more than the authorized amount by their physician. So they see their physician, the physician makes a recommendation.
Il y a un problème.
But there is an issue, there's a problem. So you don't seem to be about to go ahead with the recommendation from the committee, because even police forces cannot intervene because this is in the legislation. So when police officers need to intervene, they need to intervene because the law is being broken or violated. So let's go back to recommendation 42. The recommendation says that pharmacies should be allowed to distribute cannabis to people who have medical use authorization. But the Quebec Association of Pharmacy Owners is telling us that pharmacists are better placed to provide oversight for the medical use of cannabis, and in this way patients can benefit more from their conversations and interactions that they have with the pharmacist, because these people often use other medications at the same time. So the committee is saying that you need to take a step ahead in this direction. Will you do that? And will you allow the distribution of cannabis for medical use through pharmacy owners?
Ça se fait en Australie.
This is allowed in Australia, in France, in Germany, in Israel, in Italy, in the UK. Thank you for the question.
The distribution in retail outlets, the oversight is with provincial governments. And so if there is a desire for distribution in pharmacies, that is something that can be considered at the provincial level. The medical access is done through federal license holders, and it is something that we continue to oversee. But if there is an interest in retail outlet and pharmacies, that's something for provinces to also look at.
But the law says that distribution doesn't necessarily take place via pharmacies. So yes, the provincial governments can legislate on that, but will you be proactive when it comes to this recommendation and state that this is a more secure solution for patients?
It really does involve a collaborative approach to see with the provinces, given the jurisdiction in the space for retail and also oversight of pharmacies.
So does that mean that should we keep waiting? Because there's an expert committee that is saying that here's an important solution for the safety of patients. What I'm asking you is, are you going to promote this idea, or rather just sit back and wait that all of a sudden the provinces will decide to do that on their own? Do you have a plan with regard to this or not? Or are you telling me that the expert committee just went beyond their mandate?
No, the review committee did an excellent job and provided a number of recommendations and did extensive consultations. A number of them were directed specifically at the federal government, and a number of recommendations did involve federal and provincial and territorial jurisdictions to work together. In this space, it's important that we work with the provinces and territories that have an interest in exploring this.
Thank you very much, Mr. Thériault. We're going to go to the Conservatives for 5 minutes. Mr. Bailey, 5 minutes, please.
Thank you, Madam Chair. I'll direct my question to Health Canada. The tobacco strategy has set a target less than 5% tobacco use by 2035 countrywide. What is the current estimate of the number of Canadians that smoke cigarettes? Just a percentage.
According to 2024 data, approximately 11% of the Canadian population over the age of 18 smoked cigarettes over the last 30 days.
Does Health Canada have any updated data that has been collected since 2022 to prove the tobacco strategy is working?
So we continue to receive survey data in terms of the rates of smoking by Canadians as well as the rates of vaping by Canadians. So we continue to monitor that.
One of the four main themes of this strategy is to help Canadians quit tobacco by giving information on access to less harmful sources of nicotine. In your evaluation, would a less harmful source of nicotine include nicotine replacement therapy pouches?
So, as you know, cigarette smoking is one of the leading causes of preventable disease and premature death. We are committed to continue to help people quit smoking and keep vaping products out of the hands of children. And look at ways in which we can help smokers quit.
Data from 2022 to 2025 would suggest that the use of nicotine pouches as an alternative to smoking cigarettes had a marked decrease in cigarette sales, from the point of Health Canada regulation of about 4%. Why was the sale of pouches approved by Health Canada in the first place?
Nicotine pouches were approved as one of the products that exist in terms of other ways in which people can consume nicotine and that it is less harmful than cigarettes.
Madam Chair, I'm having trouble hearing. Can we turn up Greg's mic, or I can't hear him? No.
Can I suspend your time for a second while we find out what's wrong?
Thank you.
Okay.
I don't know, but I can't hear him, so I do have my earpiece and it didn't help.
Do you have, is your volume up on your?
It's- Okay, try again.
Okay.
Why did the former Minister of Health, Mark Holland, unilaterally ban nicotine replacement pouch sales to only behind the counter of pharmacies, making it significantly more difficult for those that wish to find alternatives to cigarettes?
I will also speak up. Can you hear me better? Okay, great. In August of 2024, Health Canada did publish a ministerial order which introduced new measures around nicotine replacement therapies. And that was done in large measure as a result of concerns that have been expressed by healthcare professionals about youth using nicotine replacement therapies like pouches recreationally.
So in order to help Canadians quit smoking and achieve Health Canada's target of 5% or less tobacco use by 2035, would it not make sense to give Canadians access to nicotine pouches?
So nicotine pouches continue to be accessible to Canadians. They're available in pharmacies behind the pharmacy counter. So Canadians who choose to use that kind of nicotine replacement therapies continue to be able to access them. And the measures that were taken by the former minister were in large measure to protect the youth from the harms of recreational use of these pouches.
Will Health Canada give Canadians the freedom to choose to stop smoking by reversing the former Liberal health minister's order and regulate the sales of nicotine pouches in the same way that cigarettes are sold? With valid government-issued ID to legal adults only to protect against youth access while supporting Canadians who wish to stop smoking?
So we will continue to review and consider many sources of evidence to inform these new rules, including data on flavor appeal to youth, for example, as well as any feedback that we get through consultations. And we'll continue to kind of consider the risk factors going forward in terms of measures that may be appropriate to mitigate harms, especially as it relates to youth, while continuing to strike the right balance to maintain access to smoking cessation tools for those who need them.
Thank you. The time is up. Mr. Bailey. I now go to Mr. Pawlowski for 5 minutes, please.
A number of us here on the committee, including Monsieur Thériault, Sonia, and I see Todd Doherty sitting over there. I think he was on the health committee at the time at the outbreak of COVID. In the weeks leading up to COVID, we had Dr. Tam here, Dr. New, I think. We asked about the assessment of the risk. We were repeatedly told in the weeks preceding the actual shutdown of our society that the risk was quote unquote low. This despite the fact that I think you could have gone into any locker room in hockey arena in Thunder Bay and asked the beer hockey team what they thought the risks were, and the majority of people would say, yeah, it's coming. So I think Public Health Agency of Canada, Health Canada, underestimated the risk. I think our response to the initial outbreak was suboptimal. And I think there's obviously been a number of inquiries looking at why that was. I know Globe and Mail had an article where they kind of investigated and talked to a lot of people as to what the problem was with PHAC. I know the Auditor General also came out with a report, but I certainly know that the Globe and Mail, one of the things they criticized was the fact that in their assessment, the Public Health Agency of Canada, Health Canada, had become heavily dominated by bureaucrats rather than medical people. And that's something that's taken place over a number of years. And they felt that that was one of the factors that contributed to our suboptimal response. Now, Madame Hamzaoui, I would note the new leader of the Public Health Agency of Canada is no longer a doctor. Dr. Tam was previously there. I do not think that you need to be a doctor to be the head of Public Health Agency of Canada. But what can you do to reassure people like me, the Canadian public, that our government has addressed the concern about having a lack of medical people? And I'm glad Dr. Sharma showed up here because she is a medical person. But how can you assure us that, in fact, you are getting the medical input and you're getting the best medical evidence in making your decisions?
Thank you very much for the question. And perhaps first off, I should clarify the Public Health Agency of Canada Act is very clear. There is a president of the agency, and that is myself. I act as essentially the chief executive officer of the organization. And there is a chief public health officer who also is part of the leadership of the agency. Those are two distinct positions. And in fact, the Act, I think, has there are four more provisions associated with the Chief Public Health Officer than there is with the President, in recognition of the very important role of the Chief Public Health Officer. Currently, the interim chief public health officer is Dr. Howard New, and there is a competitive process that, an appointment process that is underway, and we look forward to the conclusion of that process soon. What I can assure you is that the agency continues to have science and medical advice at the core of its work, and we're continuing to ensure that we bolster that to the fullest extent possible, including, for example, as I was noting earlier, in terms of the reductions, we have been very careful to minimize the reductions in those areas. For example, at the lab, it is the least impacted by the changes. And perhaps I might just note, and this goes back to an earlier question, Madam Chair, in terms of the COVID-19 pandemic, without public health measures or vaccines, there would have been up to 800,000 deaths. The observed number of deaths as of April 24th, 2022 was 38,783. Without public health measures or vaccines during the pandemic, up to 2 million hospitalizations were expected. There was 150,602. Without public health measures or vaccines, there would have been up to 34 million cases. There were 3.3 million reported cases. Those are the facts in terms of what happened during the pandemic and what the modeling shows.
22 seconds.
I'll forego further questions.
I now go to the third round, and I begin with, for the Conservatives, Mr. Strauss. Sorry.
Thank you, Chair. Thank you to all the officials who came. I used to be a public health official. I had to present myself to the Board of Health. It is always stressful, so I appreciate what you're doing being here today. My questions are for Ms. Hamzawi. And I wanted to say before I started, I noted when you were appointed that there was a lot of unfair and frankly ugly, inappropriate criticism of your appointment, and I thought you handled that with a lot of grace and composure. So thank you for your service. I reviewed this document, the Public Health Agency of Canada Science Strategy. I know it was prepared before your tenure. I don't know if you've had time to review it, but there were parts of it that I found very interesting, and I wanted to ask you some questions about it. With respect to this document, several references are made to decolonization in science. Is Public Health Agency of Canada Science currently colonized, in your view?
That essentially reflects the importance of health equity in the work that we do. So making sure that we reflect the importance of reaching all Canadians and having an anti-racist lens to the work that we do. That's how I would interpret that.
So I take it as a yes, though, that the science currently being pursued is colonized, and I wondered if you had an example of colonization in the science that the agency is currently doing.
I would say a key priority for the agency is health equity and ensuring that we reach all populations. There are some populations that are more impacted than others. There are Indigenous populations, or we have specific programs for Black Canadians. There are a number of populations that need additional supports to ensure that they receive the supports for access to health care.
So health equity is important. Health equity is in the document many times. It seems like you have a preference for the term health equity over decolonization. I wonder if you would commit to, if that's what the term means, using that term health equity more often in these documents when they are prepared.
So thank you for that. Take a look at that.
Thank you. Similarly, the report says that Public Health Agency of Canada recognizes that making meaningful action against racism in science is crucial for achieving scientific excellence. So is fact science currently racist, and what racist science will we be taking action against?
And that statement essentially reinforces that we take an anti-racist lens to our work. An example that I can think of was from when I was in Health Canada, and that's around sunscreen. And in terms of the requirements, an assumption of a lighter toned skin than a darker toned skin has an impact in terms of the kind of advice that comes forward. So that's an indicative example of what we're looking at trying to avoid in the advice, the best possible scientific advice that we can give to.
I will say that's a terrific example, and I remember it from when I was in medical school in 2004 and thinking exactly that. The report says that FAC wants to diversify its science workforce. Does this mean that FAC will strive to have scientists from diverse academic disciplines working on diverse problems with diverse methods, or does it mean something rather cruder about racial quotas in hiring scientists?
We have employment equity obligations enshrined in law, so I would say it's both ensuring that we meet our obligations for employment equity, but also ensuring that we have multidisciplinary streams of thought that support our work. So we're looking at multidisciplinary, interdisciplinary, as well as meeting our obligations for employment equity.
These employment equity outcomes, are they quotas?
They're not quotas. They are ensuring that we we engage at a rate similar to workforce availability in each of these areas.
I think you called them a mandate. Where does the mandate come from to pursue these parameters?
1 minute.
We have under the unemployment. We have employment equity obligations under statute.
Under statute, okay. If you could table those statutes later, I'd be interested to review them exactly. Is there a way to know by your lights if the what you call racial equity parameters are being met, and are they being met right now?
Sorry, can you ask the question again?
So the parameters that you have to follow under statute, are those parameters being met right now? Are the necessary requirements being met at this moment?
So I last looked at our employment equity gaps last week. This is particularly important for us as we recalibrate as part of the reductions that I was speaking to earlier. We are below. We are not meeting our targets in terms of persons with disabilities as well as with Indigenous populations. So those are two areas where we are continuing to work in terms of making sure we close those gaps.
Thank you. We now move on to the Liberals. Ms. Chi for 5 minutes.
Thank you to all the officials for attending the meeting today, and thank you for letting us pick your brain on various topics. So as we know, Canadians understand that mental health is health, and that supporting mental wellness is just as critical as treating physical illnesses. From an economic perspective, poor mental health can drive absenteeism, lower productivity, and lead to premature workforce exits. Conversely, when people have access to mental health supports and resources, whether through their family doctor, community groups, organizations, or in the workplace, they're more resilient and more engaged in the labor force. It's especially important as Canada faces demographic and workforce pressures in the years ahead. Could you outline how Health Canada's broader mental health initiatives are helping Canadians stay engaged in the workforce and support economic participation? And how do you work with provinces, territories, and partners to ensure Canadians can access these supports they need in a timely way?
Thank you for the question, Madam Chair. And you're right, mental health is highly prevalent. I think the statistics show that about 1 in 3 Canadians will experience mental illness in their lifetime. So the work that we're doing through Health Canada is one of a collaborative nature with provinces and territories and stakeholders to support a multidisciplinary system that helps integrate mental health as part of patient-centered approach to healthcare, so that it's supported and integrated as part of the continuum of care that includes, goes from promotion to prevention, to supports to services and through treatment. One of the areas of priority through the Working Together agreements to improve healthcare for Canadians was on mental health, including the $25 billion that was set aside for shared priorities with provinces and territories. And there are bilateral agreements with each province and territory that include that mental health pillar as one of those priorities.
Thank you. And what are the most common barriers that Canadians face when trying to access mental health care and support? And how are you and Health Canada working with partners to reduce those barriers?
So one of the barriers is stigma. Obviously, that's of a significant concern. So when it comes to promotion and prevention. That's an important part of the work that we do. We also look closely in respect of mental health challenges faced by youth and young people that might prevent them from participating fully in society or educational pursuits that are critical to help youth thrive. In 2024, we launched the Youth Mental Health Fund. That is an investment that's helping to improve access to care close to youth directly in communities to help youth thrive and help enable the kind of wraparound services that are important from a continuum of care approach.
And thank you. And in terms of technology, and my colleague Ms. Sidhu mentioned the adoption of AI, how that can streamline services. I was just wondering, have you seen virtual care digital platform being used to expand access, and how are those supporting or expanding services in remote and rural communities that are really tough for them to access?
1 minute.
So that's certainly part of the toolkit, and we've seen that used in a number of different ways in the context of supporting mental health and youth mental health in particular. There are organizations, for example, like Kids Help Phone, that are looking to make inroads with that. Obviously,
30 seconds.
consistent with some of the more technologically savvy nature of younger people these days. We've also seen adoption in post-secondary institutions, for example, in terms of digital tools as it relates to mental health and wellness that helps provide resources 24/7 and also helps in remote and rural communities.
Thank you.
Thank you. And I will now go to Mr. Trejo. 2.5 minutes, please.
Ma question s'adresse au...
My question will be for the Deputy Minister. On December 12th, 2024, I asked Health Canada to provide a contract, and Health Canada accepted that, and then we had the prorogation and everything. But I would like to know when you're going to provide that.
Merci pour votre question.
Thank you for the question, Madam Chair.
Happy to make available any details that are pertinent in respect of the contract, and we'd be working with our colleagues at Public Services and Procurement Canada to do so if the committee continues to want to us to proceed.
Ce qu'on veut, c'est le contrat.
We'd like to have the contract, and you promised, so we are waiting to receive the contract. You chose Sun Life to manage the program, but according to Canadian Physicians Association, patients are having to wait a lot and have a lot of patience when dealing with this company because sometimes their colleagues are having to wait for weeks and sometimes months to have a pre-approval. And sometimes additional documentation is requested, so things aren't going well. And the same dentists at the private sector going through private insurance companies, they submit the same claims and everything goes smoothly. So are you going to do anything about that?
We are aware of the concerns that existed with pre-authorization when it was introduced at the end of last year. And there, you're right, there was a backlog associated with those approvals. The backlog has now been cleared, and pre-authorization requests are being processed within service levels well within a week's time. So those have now been resolved. The Canadian Dental Care Plan is somewhat different than private sector plans in terms of how pre-authorization is used, because what it looks for is whether services are medically necessary. So it requires a slightly different approach than exists for private sector plans.
Thank you very much. I now go to Mr. Doherty. 5 minutes, please, for the Conservatives.
Thank you to our guests for being here. Mrs. Hamzawi, you rattled off some pretty incredible numbers regarding our COVID response. Can you state those again for us?
Sure, not a problem. This is actually from a publication called Counterfactuals of Effects of Vaccination and Public Health Measures on COVID-19 Cases in Canada, What Could Have Happened. And so we are happy to provide that publication to you. But in terms of the numbers, Table 1 in this publication, without public health measures or vaccines, there would have been up to 800,000 deaths. In terms of what was observed as of April 24th, with public health measures and vaccines, there were 38,783. Without public health measures or vaccines, there would have been up to 2 million hospitalizations. What was observed was 150,602. Without public health measures, there would have been up to 34 million cases. And with public health measures, there were actually 3.3 million cases.
Are these your modeling? Is this public health?
This is modeling, yes.
Can you table that with?
Yeah, we're happy to table this publication. No
Thank
problem.
you.
It's in the public domain.
How many Canadians died from opioid overdoses last year, and how does that number compare to 10 years ago?
So the total numbers of deaths in the period April 24 to March 2025. Sorry, I just.
That's okay.
No, I have the total number. That's January 2016 to March 2025 was 53,821. I have the number of opioid-related deaths at 6,601, which was a reduction of 21% relative to the year before.
So would you say the government has been successful in bending the curve on this in the last 10 years?
What I would say is we have seen a quarter after quarter for the last, I think, 4 quarters, a decrease. So we're now ready to say there is a decrease, but that is experienced at the national level. It is very different across the country. So,
right.
And there are different
Take, for
populations.
Instance, my province in British Columbia,
absolutely,
the highest rate.
Right, absolutely.
What performance metrics, if any, does your department use to measure success in reducing opioid deaths?
So our focus from a surveillance perspective is on.
But do you have performance metrics that do you have a national target that you want to hit?
We are driving to zero. So the intent is to get out of this crisis. But in terms of what we're monitoring, to be able to see progress, our number of deaths, number of hospitalizations, number of visits to the ER,
right. And are those going down? Are those going down?
So right now, last year, decreased 21% in deaths, decreased 17% in hospitalizations, 19% decrease in ER visits, and a 19% emergency service response decrease.
Right.
However, this, again, I just wanted to say is a national high-level number. It is highly variable across the country and at a
Ms. Weber, thank you for that. Ms. Weber, you stated that there was 5.3 million visits to supervised consumption sites. Was that per year? Is that last year?
No, I believe that's since 2017.
2017. Is that number going up or is it going down?
It continues with people visiting on a daily basis, so the number will increase.
Okay. So do we have a target for reducing opioid deaths? I guess 0 is the target. Okay. I'll skip to the next one. SUAP funding is set to expire this year. Is there a replacement program that's coming, or is that going to be extended?
Sorry, did you say SUAP?
Yeah.
Sorry, the SUAP funding is not expiring this year. We do have funding until 2028, and we do have A-based funding for the substance use and addictions program.
Okay.
We do, There have
1
been
minute.
top-ups in previous budgets, and some of that is coming sunsetting, but we do have ongoing funding, and then we also have some that will expire at the end of our Canadian Drugs and Substances Strategy in March of 2028.
Thank you for that. Has the department ever provided the minister with a warning that current policies were failing to stop overdose deaths? With your knowledge, under your knowledge, with your knowledge?
30 seconds.
So the department had briefed ministers in respect of the opioid crisis.
And did they follow your briefing or the information and the guidance that you provided?
They have taken advice in terms of the Canadian Drugs and Substances
Thank you.
Strategy.
Ms. Hamzawi, you're...
10 seconds.
Okay, Ms. Hamzawi, is PHAC racist? Was that your testimony earlier?
No. No, PHAC is not racist.
Okay, but I believe that's
we
kind
are
of what you were...
committed. That is not what I was saying.
Okay.
Thank you. I now go to, I think we can do one more round. So we will start with Mr. Mazier for the Conservatives. 5 minutes, please. Oh, sorry. I missed out Mr. Ayerson.
No problem.
Sorry, Doug.
Yeah, thank you, Madam Chair. Thank you, everyone. I guess I have some questions for a few of the witnesses here. Mr. Orenzak, we were talking about the tobacco pouches when Minister, now I was not in government at this time, but when Minister Holland had made changes to the regulations on nicotine pouches. Was there not a concern that these were being, under the regulations at the time, these were being sold with flavors that were considered, more preferred by younger people, and the perception that this might be increasing the use of these in young people?
Yes, that was one of the concerns that the former minister had in terms of these pouches being attractive to young people by virtue of some of the flavors that they came in, as well as how they were being promoted and advertised and packaged.
All right, thank you. And to your knowledge, there are a number of different smoking cessation therapies available. And I know addiction to tobacco in my own experience. I'm an emergency physician, and I know how addictive this substance is. Is there any evidence that you're aware of that nicotine pouches as a smoking cessation tool are superior to the more conventional approaches like nicotine patches and nicotine gum?
I don't have that available with me. I can take that back. I think nicotine pouches have been a fairly recent product that's been introduced on the market. So the department continues to look at all kinds of evidence in respect of a variety of smoking cessation tools.
Thank you. There's also been, a lot of promotion, a lot of industry-sponsored promotion of the use of vaping as a smoking cessation technique. Are you available of any data that this is an effective smoking cessation technique compared to the more traditional approaches?
Going to ask Ms. Weber to jump in on that one.
Thanks. Thank you for the question. So smoking cessation products that are approved by Health Canada meet safety, quality, and efficacy, and are approved for as a therapeutic product or a natural health product. We have not approved any vaping products to date for smoking cessation for safety, quality, and efficacy. We do know that individuals use a variety of tools for smoking cessation. Cold turkey is probably the #1 and most effective that people have used. We have seen people use nicotine replacement therapies, as we've just discussed, and then some people have indicated they have stopped smoking using a vaping product.
All right, thank you. How much time do I have, Madam Chair?
You have 1 minute, 47 seconds.
Thank you. Now, is there any evidence that there is, if someone starts vaping, if someone has not been exposed to tobacco at all, the likelihood that they will go on to smoking cigarettes if they start vaping versus those who don't try it at all?
So vaping as a gateway for smoking, it's still early days. We don't have evidence at this point that vaping is a gateway to smoking. We monitor it closely, but you know, the Tobacco and Vaping Act was just passed in 2018. So it's been legal in Canada for just a few years, and we continue to monitor it closely.
Thank you.
7 seconds.
Okay, thank you. Ms. Weber, going back to supervised consumption sites, is there any evidence that these sites promote or increase the likelihood that people will take illegal drugs?
They actually are a safe place for people to go into to use the drugs that they're currently using.
All right. And in regards to the selection of sites, there are people that will object to them being in certain places. I remember Manitoba was setting one up. Do you not? Are they not set up where people are actually already using drugs?
The communities come in and they come in with an application with a site that they have picked. It's based on the public health needs in that community, in that area in the community, the public safety needs of that community, and then also they do community engagement. So the community comes forward with the location. They provide that evidence and the information to the department, and then the department assesses the public health and public safety balance of that request.
All right, thank you. How much time do I have?
That's it.
Thank you.
Well, you have 20 seconds. No, you're good? Okay, thank you. Go to one more round. I think we can fit that in. Mr. Major for 5 minutes.
Thank you, Chair. Just to follow up on Mr. Evelson's line of questioning, Ms. Weber, does Health Canada have any concerns with approving supervised consumption sites next to a school? Yes or no?
It's important that we look at the application.
Just a yes or no.
In.
Do you have any concerns with that?
It is part of the consideration when an application comes in. The community that is coming forward needs to consult with the community, including nearby schools.
So you have concerns. What are those concerns?
It's a consideration is the engagement with the community as to their concerns or their support for the supervised consumption sites.
Health Canada has no concerns then?
The location of the site and the engagement with the community is important when they come in and is part of the application, and we review that when we assess whether there's an approval or a rejection of the application.
Will safe supply be continued by this funded be continued to be funded by this government?
Health Canada funded 31 projects and is no longer funding safer supply projects. They were funded under our SUOP program, which is the Substance Use and Addictions program, and that program is to test innovative solutions to responding to the overdose crisis. And so in this case, we did fund the sites, and then it is up to the provinces and territories whether they want to scale up or continue with those supervised consumption, safer supply or prescribed alternative sites.
Is any funding provided by Health Canada or the Public Health Agency of Canada being used to purchase crack pipes?
No. No.
According to the Globe and Mail, a foreign drug maker named Grifols is using Canadian donated blood plasma for products sold offshore. This is despite a promise from Canadian Blood Services that all products made from Canadian blood donations would stay in Canada. Is Health Canada investigating this? Yes or no?
So the contract with Grifols is with Canadian Blood Services, so they would be able to answer questions associated with that. We are not investigating this at the moment.
And yet Health Canada is responsible for the regulatory oversight. So you're not investigating it, correct?
We're not a part of that contract.
Okay, thank you. I'll cede my time over to Ms. Kodans.
Thank you. Through the chair, the I'm going to ask a question to Ms. Weber again about the 2023 agreement with the BC government and the federal government for decriminalization of drugs, only in BC at this point. My question is, have other provinces asked to join this decriminalization program?
We do not have any other exemption requests in front of us for review. There were others that had considered it in the past, but we do not have any other provinces that have approached us currently.
Ms. Weber, why do you think there have been no other requests from any other provinces to join this program?
It's not a program. It's an exemption request that comes in from a jurisdiction. In the case
of pilot project, correct?
It's an exemption actually from the Controlled Drugs and Substances Act, and the province of BC came in as part of their comprehensive approach to responding to the overdose crisis. Each jurisdiction, it is up to those provinces.
Thank you, Ms. Weber,
should they choose
for
to come
answering
in.
that question. I have a question about
1 minute.
The suspension of the program, the possible suspension of the program, if it's deemed that it's not safe. There's been multiple communities in British Columbia who are crying out, and RCMP, first responders, for this program to end. This exemption, from what I understand, may be suspended without prior notice if the minister determines that such suspension is necessary to protect public health or public safety. Under what circumstances will you advise this? Like,
30 seconds.
Under what circumstances would you say you would suspend this program, this pilot project?
So, as noted earlier, is that we monitor it closely, and the province of BC they monitor it closely and they engage with stakeholders. We've amended it twice over the past 2 years at the request of British Columbia, given concerns from law enforcement.
Thank you, Ms. Weber. Do you believe this is a successful program?
You have 2 seconds to answer, Ms. Weber.
As noted earlier, the exemption expires in January of 2026.
And it's successful.
Thank you. I now move to Mr. Pawlowski from the Liberals. 5 minutes, please, Mr. Pawlowski.
So I got to say I'm a little confused here on this line of questioning from the Conservatives. I thought we'd reversed, yes, BC decriminalized the use of drugs, but I thought they asked specifically to reverse that, and I thought we had done so. No, what is the status of that currently in BC?
So they have requested 2 amendments to their exemption. And so the most recent amendment, the minister approved, the previous minister approved, and now it is limited to personal possession in private homes, in shelters, or addiction clinics. And so public use is not allowed, is not permitted, outside of those locations I just listed.
Okay, and a second point of clarification, it seemed to me you said, but I just want to confirm that this is true, on the issue of safe supply, you said there is no longer any safe supply being funded by the federal government through the SUOP program?
That is correct. It ended March of this year.
Okay, my next question is to Mr. Orensek. I think you said that our government was taking concrete steps to facilitate foreign nationals getting in the healthcare field, being credentialed in Canada. I know healthcare is an area of shared jurisdiction, but certainly licensing is under the provinces. What specifically is our government doing in order to try to facilitate licensing of foreign nationals?
So there are almost 200,000 internationally educated health professionals who are employed in Canada. They form an important part of the health system, helping to address some of the workforce shortages through the skills that they bring to the Canadian healthcare system. As much as credential recognition is within the domain of provinces and territories, we are working with our health system partners in a number of areas to help streamline immigration and foreign credential recognition processes, and to support recruitment, integration, and also the retention of internationally educated health professionals to support health systems.
Can you point to any successes in this? I know as a physician, having spoken to the Ontario College of Physicians and Surgeons, that we have implemented a, what's the name of the program? I'm trying to search for the name, the one where it allows evaluation of foreign credentials over a 6-week. Maybe you can fill me in on what's the name I'm forgetting. But it seems like the program has not really resulted in a lot of people being credentialed. But
yeah, so I think you might be referencing licensing of physicians. There's been an Atlantic registry that's been sort of on the leading edge of that. And you're right, we are supporting processes by which we can help streamline licensing and information sharing between regulators in particular, so that they don't have to duplicate work and they have the ability to go into kind of one system to be able to check for the most up-to-date information on the licensing of physicians.
There's certainly been a call for national licensure. I think Australia has kind of converted from state-based licensure to national licensure. There's been a lot of talk in Canada about national licensure. What, if anything, has been the progress towards that? And I'll give you a great example of how that's a problem. Dr. Elifson here is an emergency room doctor in Winnipeg. Kenora Emergency Room had not enough physicians and was looking at closing, but someone from Winnipeg, even though it's a 2-hour drive from Kenora, couldn't go there without first getting licensed in Ontario. This made little sense when I, as a Thunder Bay Emergency Room, are we any different? No, I don't think so. And it's a 6-hour drive from Thunder Bay. So,
14 seconds.
Again, any progress on this? Yeah, so there has been progress and momentum, and we're working with FIMRAC in particular and engaging provinces and territories to support more of a national licensure model for physicians. And we're optimistic that there are a number of provinces that are keen to help address these challenges. Spoke about Atlantic Canada in particular. They've been at the forefront of this, but other provinces are also participating.
Thank you, Mr. Ornsack. I now go to Mr. Tayo. 2.5 minutes, please.
Thank you, Madam Chair. Mr. Ornsack, Health Canada, it is notoriously known as having a hard time approving drugs. I've been raising this for years at this committee. Some drugs are authorized in the U.S. and have been approved since 2023. In Europe since 2025, 2024 in the UK, 23 in Japan, 2024 in China, and in Canada, the same drug has yet to be approved. It's in the process, but are you lacking staff?
So, thank you for the question. Our approval timelines and standards, if you look at the overall statistics, compare quite favorably to other G7 countries. Last year, the department completed 97% of new drug reviews and 84% of generic drug reviews within
Excusez-moi, ça fait 6 ans.
Excuse me, it's been 6 years now. I could list a number of drugs, and there have been problems for 6 years now in terms of approval. I'm asking you if you're lacking staff. Can you answer that question, yes or no? Are you lacking staff to be competitive when you look at other authorities like the FDA? And when things are authorized at the FDA, why don't you do a study rather than wait at till the very end of the process to start the assessment. There are so many solutions. You know, I've been proposing solutions for 6 years. Nothing is changing. What do you have on all of these other countries? What are you doing with this?
30 seconds.
So, two things. We are deploying staff and resources to support drug approvals. We're confident that we have adequate capacity to support drug approvals, but we're always looking to increase that if possible. We're working with other trusted partners to support mutual reliance so that if one regulator approves a product, we might be able to rely on their approvals, which would help in terms of accelerating drugs. I would also say that getting products to patients is not only up to Health Canada. We work with provinces and territories in terms of their listing processes, which is often what takes more time.
Haley for the Conservatives for 5 minutes, please.
Thank you, Madam Chair. I'm going to start by asking, why is it easier to buy cigarettes when we want people to stop smoking? Why aren't we allowing these nicotine replacement pouches to be bought in convenience stores like cigarettes?
So the ministerial order in respect of nicotine replacement therapies was put in place as a way to protect youth from harms of nicotine replacement therapies, nicotine replacement pouches. That was the reason behind the ministerial order.
But cigarettes are still available with proper ID. Why can we not have the same for replacement therapy with the nicotine pouches?
The ministerial order was put in place again as a ways in which we can protect access by youth.
6.5 million Canadians without doctors, and not once did I hear we're going to do something in Canada like increase or help the provinces get more seats in the universities. Are we not looking at this, Health Canada? Are we not looking at other ways other than looking at immigration for future doctors?
We are looking at other ways as well to support the health workforce. We are working with provinces and territories, including through programs to help increase the number of residency and training positions at universities to help train more doctors and other health professionals.
With the lack of specialists, we are only going to see increased waiting times. We're only going to see more situations like went on in Thunder Bay. We need specialists, and without increasing the spots here in Canada, we're constantly running out of anesthetists. Is Health Canada going to take a serious look at helping the provinces with these specialists?
We are working with provinces and territories. The delivery of healthcare is, as you know, within their jurisdiction. Some of the priorities under the Working Together agreements speak very directly to helping to increase access to care for Canadian patients, and those investments are intended to support a variety of initiatives that are being advanced.
Okay,
by
thank you for
provinces.
that. I have one last question. I will be sharing my time with my colleague, Dr. Strauss. How many recovery spaces does Health Canada believe are necessary across Canada to address the opioid crises?
Thank you for the question. The treatment beds and the recovery spaces are in the jurisdiction of the provinces and territories. We have transferred money through health transfers to support them and funding those. It
Okay,
depends.
thank you. Just looking for a number.
The rates
Thank
do
you.
differ by province.
You have 1 minute, 24 seconds, Mr. Strauss.
Ms. Hamza, we had a few more questions about the science strategy report. I think I had asked, does this phrase diversify the scientific workforce mean racial quotas? And you said something, I think, no, it means employment equity targets or goals. Do I have your phraseology correct?
Our obligations towards the Employment Equity Act. So we have obligations to meet in terms of...
And how, in your view, are those obligations different from quotas?
Sorry?
How, in your view, are those obligations different from quotas?
They're not. They're essentially they're relative to workforce availability. So if there's a certain proportion available within the workforce, then we should be representative of the country.
Okay, I mean, so that sounds rather like quota to me. Do these targets or these obligations include, and I ask partly because my family fled a communist country as a religious minority, do these targets include religious minorities?
The religious minorities are not specifically named in the employment equity.
Interesting. The report, a bit of a change of topic, mentions
40 seconds.
Mentions the Healthy Canadians podcast. I note the last episode was on YouTube, put up on YouTube 8 months ago. It got 4 likes. Has it been discontinued?
Not to my knowledge. I'm not aware of the podcast being discontinued. But just to be clear on the Employment Equity Act, it includes women, Aboriginal peoples, Indigenous peoples, persons with disabilities, and members of visible minorities.
I now go to Ms. Sidhu for the Liberals for 5 minutes, and I really need to do some homework with us. So when we finish with Ms. Sidhu, I'm going to ask our guests to leave, and we can just quickly do some homework. It's not going to take us long, maybe 3 minutes, 5 minutes, but I'd like everybody to be very precise because I'm going to stick to the time. Thank you.
Thank you, Madam Chair. My questions to Health Canada. Chronic diseases like diabetes, cancer, cardiovascular diseases, it's the main leading causes of deaths and disability in Canada. We know many are the preventable. Can you explain how our federal investments and programs like the Healthy Canadians and Communities Funds are helping Canadians so they can adopt healthier lifestyles and they can prevent from those diseases?
I'm going to ask my colleague from the Public Health Agency to answer that, given the programs that you're asking about.
Yeah, they can answer.
Great, thank you very much. And indeed, more than 2 out of every 5 adults over the age of 18 living in Canada have at least one chronic disease, diabetes, cancer, heart disease, and the proportion is even greater among populations that experience conditions of social and economic disadvantage. So yes, the prevalence is increasing. In fact, the agency is working with our partners in provinces and territories, community organizations. We're working in 3 buckets of work. The first is with respect to surveillance and research, and you can find that online on the Health Info Base. The most notable is the Canadian Chronic Disease Surveillance System, which is a collaborative network of provincial and territorial surveillance systems that is supported by the agency. It includes things like cardiovascular diseases, musculoskeletal, so a number of diseases there. The work that we do in terms of analyzing national data to monitor trends, for example, the Cancer in Young People in Canada program. We also lead the Pan-Canadian Health Inequalities Reporting Initiative to strengthen the measurement, monitoring, and reporting of health inequities. We have indicators of individual behaviors that we're tracking, the physical activity, sedentary behavior, and sleep indicators. A second key bucket is the work that we do in terms of guidance. So, for example, the work of the Canadian Task Force on Preventative Health Care. That particular body is being modernized at this point in time, and we look forward to that organization relaunching in a modernized form. And there are other guidelines, as I noted, the 24-hour movement guidelines. In terms of funding programs, we have the Healthy Canadians and Communities Fund, which supports healthy living among those who face inequalities and are at greatest risk of developing major chronic diseases such as diabetes, cardiovascular disease, and cancer. The fund provides approximately $20 million annually and leverages additional funding from other partners and supports projects that focus on addressing behavioral risk factors to chronic disease. We also have an intersectoral action fund, which supports community capacity for upstream collaborative action that addresses things like poverty, food insecurity, and supports preventative health measures by reducing risk factors that lead to or worsen chronic diseases. There's also the work being done on diabetes, so the government's investment of $35 million over 5 years for diabetes research, surveillance, and prevention, and the work that we're doing under the framework for diabetes in Canada. We have also an important partnership with Participaction, as well as some of the funding. Other programs that we have are the Community Action Program for Children and the Canada Prenatal Nutrition Program, almost $80 million in that area too.
And also want to mention celiac disease. Is there any current guidelines for the food establishment and food operators in serving gluten-free? Because the quality of life is impacted when someone consumes gluten. So just want to know that.
In terms of agency-specific guidelines, I don't believe we have the agency having specific guidelines in the area, but I'm certain there are others who are very active in this space, and so we'll watch that closely. Thank you for noting that for us, Madam Chair.
Thank you. And women's health has historically been under-researched and underfunded, which has resulted in gaps in care and outcomes. In recent years, we have seen a stronger federal focus on addressing these gaps. How you can address those gaps?
I would like the answer to be concise. Thanks for your 28 seconds.
We're working with a number of partners, including the Canadian Institute of Health Research, for example, in terms of evidence as it relates to some of the gaps that you've observed. It's also an area where we are able to work closely with provinces and territories as it relates to the health programs that they offer.
Thank you very much. I will now like to thank the witnesses for coming and having to answer a barrage of questions. Well done. And I'm going to ask if you would please leave so that we can move in camera to discuss just some business quickly. We have 5 minutes. Thank you. Do we have to move in camera? No, we don't.
That will take 10 minutes.
Yeah, no, okay. So we won't meet in camera, guys. It'll take too long. Let's do this quickly. So, we're resuming the business part of the meeting. Please, can you take your seats so we can get this done? We have 5 minutes to get it done. Please. Members, can you please take your seats? Thank you. Now, we have 3 budget studies. I want to ask you to look at your, you've been sent the calendar, et cetera, and the 3 budget studies. I need your consent to adopt the budgets. One is for the study on women's health. The other is for our upcoming meeting with the Minister of Health. And the third is for our meeting with Health Canada today. I have signed those. Are you okay with them? No, nobody against it? Okay. You have a draft calendar in front of you, and it was based on the motions adopted during the last meeting with studies that the committee will undertake and the priority for those studies, and that's been circulated. And as well as requesting you to meet the deadline for witness lists for the upcoming study Mr. Major put forward. So I want to remind you that the deadline to submit lists for the study on the impact of immigration policy on healthcare and barriers to integrating internationally trained professionals is Friday, October the 10th at 5 p.m. And so everyone, please submit them in that time so we can move on with the studies. And I suggest that briefs submitted do not exceed 2,000 words. Are there any objections or any comments? No? Everything's cool? Okay, so our next meeting will be October the 7th at 11 a.m. on the study. Yes, so sorry, Mr. Major?
Just to confirm, the minister is coming on the 9th for 2 hours?
Yes, it's in your calendar.
She'll be here for the full 2 hours.
Yeah.
Okay.
Yes.
Thank you.
Thank you. Thanks very much. So I adjourn the meeting. Thank you.